Hello, I'm Dr. Marla Shapiro. I'm a past president of the Menopause Society, and today I'm joined by Dr. Sheryl Kingsberg. She is a clinical psychologist and chief division of behavioral medicine in the Department of OB-GYN, University Hospitals Cleveland Medical Center. As well, she's a professor in the Department of Reproductive Biology, Psychiatry, and Urology, Case Western Reserve University School of Medicine in Cleveland, Ohio. Thank you for joining us.
It's always a pleasure to be with you, Marla.
Well, you're no stranger to this topic, and please, educate us because we're going to be talking today about HSDD or hypoactive sexual desire disorder. So walk us through, for so many of us who see it but don't necessarily acknowledge it or really understand it, how it presents and how we should be screening for it in a primary care or a gynecology setting.
Sure. Well, the reason I'm no stranger to this topic, nor is the Menopause Society, is because it is the most prevalent sexual concern for women of all ages, particularly midlife women. The prevalence in midlife is about 14.5%. So well over 1 in 10 of your patients are suffering from hypoactive sexual desire disorder. And unfortunately, it still is underground and clinicians are uncomfortable asking about it. I don't think they feel particularly trained in this.
Yeah.
So let's talk about what it is. Hypoactive sexual desire disorder, HSDD, rolls off the tongue better that way, is really the persistent loss of sexual interest, desire for sexual activity. And in order to meet the criteria for a diagnosis, there also needs to be personal distress. So if somebody says they have no desire, they're not bothered by it, you wouldn't necessarily diagnose it or try to treat it. But most of the women coming in, and they certainly come into my office, are really distressed by it because they used to have drive, that is the appetite for sexual activity, either thoughts, feelings, fantasies, not as particularly common for women to say they have fantasies, but sort of an appetite for sexual activity. Or they will acknowledge that they used to not have much drive, but they had responsive desire. So there are two kind of flavors to desire. One is spontaneous, that is on their own, they were hungry for sexual activity, or they weren't necessarily interested to begin with, but once they got started, the desire kicks in. As I've mentioned many times before, it is kind of like how I feel about working out. I have no spontaneous drive to go to the gym, but once I'm there and my heart rate's up, I've worked up a little sweat, then the desire kicks in. So that would be responsive desire. So these women would say, even in those circumstances, they've lost their appetite. Many women can go through the motions of having a sexual encounter and may even have an orgasm. It's the interest that is lagging. They want to want. That is the key. If women say, I've lost my desire and I want it back, that would be HSDD. So in terms of assessing it, it is really very easy in a clinical setting. It doesn't take all day. I know you have less than 15 minutes, probably 12 minutes for the entire visit, but there are nice screeners like the Decreased Sexual Desire Screener, which is in the public domain. It's 5 questions. Women can complete it online. They can do it in the waiting room, or they can do it with you if you want. It takes less than a minute to do, and that will screen for acquired loss of desire. You can ask in your clinical setting, honestly, if you just say, many of my, peri-postmenopausal women will have concerns with desire. What concerns do you have? That opens the door and it won't take all day. Right?
Yeah, that's sort of, it's normal for many women, or we see it a lot. You're not alone, because many women feel completely isolated in this and don't particularly want to admit to it.
Well, not only don't they admit to it, they don't know that it's okay to bring up in your office, and they don't know it's actually a condition. They think, oh, maybe it's just about aging. Maybe I should just learn to live with it. But if you can acknowledge that that you can validate for them that they're entitled to sexual health and that there are things we can do for it, the relief is amazing, and you look like the hero, even if you are not going to be the one to treat it. All you need to do is ask and refer.
So we talk about this notion of a biopsychosocial approach, which is, not just one question, but this global approach. So talk about how that is something we can incorporate into our assessment and treatment.
Well, I do think that desire is best understood from this biopsychosocial approach because a lot of times there are factors that contribute to loss of desire. And if you're thinking as a clinician, how do I want to approach treating it? If you look at the four components in a biopsychosocial model and ask about them, women are pretty smart about knowing which components are compromised, and that will guide you to treatment. So the four components really are biologic components. We know that first of all, disease factors, hormone status, neurochemistry, all can contribute
Right.
to loss of desire, right? So we look at, if they had spontaneous desire and there seems to be a medical reason for the change, that's in the biologic component. On the psychological component, depression. We certainly know that peri and postmenopausal women may be at more risk for depression. And depression, one of the signs of depression would be loss of sex drive. On the other hand, loss of sex drive can make women feel depressed. So it is bi-directional, but depression, anxiety disorders, body image issues can all lead to problems with desire. So you want to address whether those conditions are present. Sociocultural factors. Unfortunately, still in this era, women still have this sort of stigma around their sexuality. So many women are sort of ashamed to feel entitled to their sexuality, and that can inhibit their sexual desire. And finally, interpersonal factors, right? The quality of a relationship, if she's in one, that a woman is in can certainly impair her sexual desire. So, for example, she may have all the biologic factors contributing to good drive, but if she's not happy in her relationship, she's not going to really want to sleep with her partner. So, to me, very easy to think about looking at all those four components. It takes less than 2 minutes. Women will be helpful in giving you those answers. Yes, I have drive. I can't stand my spouse. Gives you a very clear focus of where you want to go. So there are biologic treatment factors. There are psychological treatments, cognitive behavior therapy, mindfulness, and sometimes the combination.
So can this overlap with other female sexual concerns? Because often we think, okay, you've identified this, that's it. End of the looking.
Yes, they often overlap. It doesn't mean that you wouldn't want to treat low desire, but they absolutely overlap. So, if you have no desire, then you're probably not going to be easily aroused, and that may inhibit orgasm. And if you're not aroused, you may have lubrication problems because you're not interested, and that can create pain with sexual activity. So you really want to look at which factor is the primary one. And I'm telling you, women are smart. They will tell you, I don't have desire and therefore I don't ever get aroused, versus a woman who says, I have drive, but every time I try to have penetrative sex, it hurts. And so I don't really want to have it. Well, that tells you that's genitourinary syndrome of menopause. Want to treat that.
Okay, so if we've treated GSM and we've ruled out the other things and we're focusing specifically on the desire with distress, treatments that are effective and available, and please tell me why we're not using them.
We're not using them because we're not asking. So that's the simple answer to that one.
Yeah.
There are a few pharmacologic options that are available, but not approved in postmenopausal women, except if you're in Canada. For example, flibanserin is a CNS drug. It's non-hormonal. It is approved in premenopausal women. We have the data in postmenopausal women, and yes, Canada has approved it through women through age 60. But not in the US. So it would be off-label, which is why I think many clinicians are uncomfortable prescribing it. But it has been shown to be safe and effective in postmenopausal women. We have bremelanotide, which is a melanocortin agonist receptor, which is actually an on-demand treatment. So flibanserin, you take every day. It may take 8 to 12 weeks to show an effect. It may cause sleepiness, but particularly for postmenopausal women, they like the fact that they sleep better. With bremelanotide, it is an auto-inject. It's like an EpiPen, and it works on demand. So within about 45 minutes, lasts about 16 hours. Biggest side effect is going to be nausea, but typically goes away after 1 or 2 trials. And that works on melanocortin receptor agonists, both approved in premenopausal women. No data that it wouldn't, these are CNS, these are non-hormonal treatments.
Right.
There's no, physiologic reason it wouldn't work in postmenopausal women.
I think one of the most important things also that you've said here to remind our practitioners is that it is a CNS drug. And just as with antidepressants, you expect 6+ weeks to see the maximal benefit, for women who try this and come back 2 weeks later and say it's not working, not to, say, oh, that's, okay, let's give it up. That period of time for it to work is really important to underscore here, I think.
That's really true for flibanserin, because honestly, the way
Yes.
women will say it's like, I had no drive, I was almost dreading it, and then it kind of gradually moves into,
Right.
I had my own. Now, the bremelanotide, really, you give it 2 or 3 tries, you get it in a 4-pack. If it's not working by 4, it's probably not going to work. So you'll have a quicker response and know whether somebody is a
Right.
responder or not with that. And then finally, of course, what we've been using for decades is exogenous testosterone as a gel, typically, because we do not support the idea of using it orally or injectables, but we're
Right.
trying if you look at the global position statement that North American, or at that time, North American Menopause Society, the Menopause Society was part of, and ISWISH has clinical guidelines, ISWISH being the International Society for the Study of Women's Sexual Health. We have clinical guidelines that are published and in the public domain for how to use testosterone in peri and postmenopausal women who have HSDD. Again, unapproved. It is an off-label use, but we know that about 20% of prescriptions for these male gels and topical treatments are used off-label for women. So you're using about 1/10 of a daily dose for men that can be used in postmenopausal women. Again, takes a long time, maybe a 12-week trial. You're just trying to get women into their premenopausal levels. No supraphysiologic dosing, none. We're just trying to move them back to essentially what they had in their mid to late 30s. And so empirically, taking labs of their testosterone levels before they try isn't going to really tell you much. So we look at making sure we do the labs after they've started, so that women aren't thinking if a little is good, a lot is better.
Yes.
Just to get them into their premenopausal levels.
Okay. I think that this is a topic, when that 14% is really a number worth repeating for primary care and OB/GYN, because 14%, we're seeing a lot of women, and we're probably missing this because it's that sort of Pandora's box. We may not want to open it, and patients feel they're embarrassed, or they may feel there's nothing to do about it. So truly an important conversation for us to have had. Thank you so much for joining us.
I have one more point.
Yes.
There is that disconnect that, the assumption is if it was something they could treat, they would ask me, the patient says. And so they're waiting for you to open the door.
Right.
And you're thinking if they had a problem, they would tell me.
Right.
So please don't have that sort of conspiracy of silence. Just ask. And, I'm a clinical psychologist. Let me still mention cognitive behavior therapy and cognitive behavior mindfulness behavior therapy really can also be effective. So some women will respond to therapy, some women to pharmacotherapy, and some women to both. Please keep the door open. Just ask.
Right. Get rid of the don't ask, don't tell mentality. Absolutely. Thank you so much. I appreciate you being here.
My pleasure. Thank you.